Welcome back. Let's continue. Preload reflects the degree to which cardiac muscle cells, the myocardium, are stretched just before they contract. The preload controls stroke volume. In the normal heart, the higher the preload, the greater the stroke volume will be. The preload depends on how much blood is in the ventricle before contraction. It is the EDV. Increased preload causes an increase in stroke volume based on the Frank-Starling relationship. Contractility is the ability of the tissue to shorten in length after receiving a stimulus. An increase in contractility will result in greater force and a greater stroke volume. Various factors affect the contractility of the myocardium. Contractility is determined by the intracellular calcium level, which in turn depends on the amount of calcium released from sarcoplasmic reticulum during excitation-contraction coupling. Sympathetic nerve releases norepinephrine or noradrenaline, which increases cardiac contractility by activation of beta receptors on myocardial cells. This is called a positive inotropic effect. Substances that increase contractility are called positive inotropic agents. Hormones like epinephrine, thyroxine, and glucagon, drugs like digitalis, and elevated extracellular calcium are all positive inotropic agents. Parasympathetic nervous system, on the other hand, inhibits cardiac contraction by activation of acetylcholine receptors. This is called a negative inotropic effect. Negative inotropic factors impair or decrease contractility. These include acidosis, hyperkalemia, and calcium channel blocker medications. Afterload is the pressure that the ventricles must overcome to eject blood. In healthy individuals, afterload is not a major determinant of stroke volume because it is relatively constant. However, in people with hypertension, afterload is indeed important because it reduces the ability of the ventricles to eject blood. In persistent high blood pressure, the afterload is chronically elevated. ESV rises and the myocardium hypertrophy develops. While initially being able to counteract the increased afterload, eventually the myocardium becomes progressively weaker. Now, let's see how heart rate is regulated. Heart rate affects cardiac output. Emotional or physical stressors like fear, anxiety, or exercise activate the sympathetic nervous system, and norepinephrine is increased. Norepinephrine activates beta-1 adrenergic receptors in the heart. Therefore, the SE node fires more rapidly, and the heart responds by beating faster. The parasympathetic division opposes sympathetic effects and effectively lowers the heart rate when a stressful situation has passed. Under resting conditions, both autonomic divisions continuously send impulses to the SE node of the heart, but the dominant influence is inhibitory. For this reason, the heart is said to exhibit vagal tone, and heart rate is generally slower than it would be without vagal innervation. Hormones like epinephrine and thyroxine can increase heart rate, thus increase cardiac output. The heart's pumping action ordinarily maintains a balance between cardiac output and venous return. In congestive heart failure, the heart fails to pump adequate blood to meet tissue needs. Cardiac output decreases. The blood remains in heart, increasing the pressure in the atria. Venous return decreases, leading to accumulation of blood in body tissues, which deprives body cells of oxygen and nutrients and the ability to eliminate metabolic wastes. The increased pressure in the left atrium causes congestion in the lungs, resulting in fluid accumulation in interstitial spaces, that is, pulmonary edema. Similarly, peripheral congestion leads to ascites and edema of lower extremities. Now let's come back to Mr. Lin. He has developed heart failure. His past history of chest pain suggests blockage of the coronary arteries. Coronary blood flow is insufficient. Oxygen supply to myocardium is inadequate, which impair the pumping function of the heart. An active inotropic state develops in the ventricles, resulting in decreased contractility and decreased stroke volume. This is why he has a reduced ejection fraction. In order to maintain the cardiac output as much as possible, the heart compensates by beating faster. However, the cardiac output is still inadequate to maintain a normal blood pressure. That's why Mr. Lin has an increased heart rate but a lower blood pressure. Poor ventricular function causes inadequate oxygenated blood supply to the tissues. Therefore, peripheral cyanosis and fatigue develops. Decreased cardiac output results in systemic congestion. Accumulation of fluid in body organs produces edema. Pulmonary edema results in breathing difficulties. Lying flat further increases venous return and elevates pulmonary venous pressure, which exacerbates pulmonary edema. Sleeping with piles of pillows can reduce the symptoms of shortness of breath. In summary, cardiac output is the amount of blood pumped out by each ventricle in 1 minute. Stroke volume is the amount of blood ejected by a ventricle with each contraction. Cardiac output is directly proportional to heart rate and stroke volume. Any factors that change stroke volume and heart rate would alter cardiac output. Stroke volume is mainly determined by preload, contractility, and afterload. Heart rate is regulated by autonomic system. Sympathetic nervous system increases heart rate, whereas parasympathetic nervous system decreases heart rate. That's all for today. Next time, we'll talk about regulation of blood pressure. Thank you, and see you next time.